there's no sense that it is bad. I mean, I had a car accident a long time ago. That was like immediate, sorted out. Surgery got to do, all was happening. It was like completely like public healthcare service, but there would be no private option that would be superior to that. But as you say, aftercare is weak. Nutrition, I think, is bad as well. Like the food is no good, right? And all of the non-emergency care, I think there's obviously like huge queues, and availability of service is poor. So
absolutely. I think it's funny you mentioned the nutrition thing. So I think one of the challenges, so I was a low risk surgical patient, young, fit, healthy, uncomplicated appendicitis. And so the way it works is you wake up in the morning on the ward, and there's a risk assessment that takes place of who needs surgery the most, right? And inevitably I'd be kind of bottom of the list, right? Because I'm stable. And so the problem is you're kept nil by mouth the whole time, right? So you're starved, you're dehydrated, you're deconditioning because you're just kind of lying there on the bed. And I guess it's not great conditions for surgery if all of those three things come together, and then suddenly you have somebody's then cutting you open, and then you've got to recover post-op. So obviously your recovery is going to be protracted, but then it's balanced out by the fact that you're a relatively kind of high physiological reserve if you're young and healthy. So yeah, it's very interesting how the decisions work, and they're all driven by the lack of resources. Really very, very difficult, but that pressure has created an extremely efficient system when it's needed. So for example, in emergency situations.
Yeah, really, really interesting. Folks, we're dropping straight into this conversation because I was complimenting Sam on his new haircut, only for him to reveal that it's come as a result of him having a revelation about simplifying his life, having been to hospital recently for surgery. And this was appendicitis. Thankfully, Sam looks okay. And he's been telling me about his experiences there. But obviously, so relevant for our topic today, about how, the healthcare service is, the goods and bad of it, where is there a staffing problem, and how indeed people in the recruitment space can make a contribution to improving something that we all need to care about. Aging society, we're all touching sort of moments where we need access to healthcare. How can we make sure that it's adequately staffed? Not only adequately staffed, but staffed with skilled, motivated, empathetic, and well-compensated people. Like, you need to kind of create a situation where people want to work in the healthcare sector and have the skills, both hard and soft, to do a great job here. So folks, this is what we're going to be talking about today. It is sustainable healthcare, sustainable recruitment in healthcare, strategies for 2024 and beyond. For the people who kind of were registering on this a couple of weeks ago, obviously we had some technical issues and we had to abandon the conversation. We're replaying it here today. And I think just looking at some of the streams, it looks like we're going okay with the tech side. So we're not having a horrible experience for everybody. So firstly, let's set the scene. Thank you for joining us, Sam Desi. Sam, why don't you quickly introduce yourself? Who are you? What it is you do?
Hey, Hung, and hi, everyone. My name is Sam Desi. I'm the founder and CEO of Pop AI. We develop digital resources for recruitment teams. So essentially, all of the kind of repetitive manual burden of the recruitment process at the top of the hiring funnel, our product takes care of, but in a very responsible and ethical way. We use AI extensively, but responsibly. And we ensure that humans are kept in the loop just when it matters. Now, that's really kind of where we differentiate, and we tend to work with large companies, enterprises, and already working with some of the largest kind of staffing enterprises in the world, like Randstad Digital and Robert Walters. So it's great to be here. I guess the other relevant thing to mention is I used to be a doctor, and the very first product I ever built was a workforce staffing platform for the NHS. Which ultimately failed, but amazing experience and taught me a lot about the HR difficulties in the NHS. Then after that, I worked in the Department of Health as the head of emerging technology, where I came kind of right up close and personal with hiring challenges during the COVID pandemic. So yeah, and that's yeah, now we're here.
And now a recovering patient who's soldiering on, having just come from surgery. It must be just a week or so ago, Sam. So you must be in a little bit of discomfiture. So thank you so much for stepping, being willing to continue to have this conversation with us. Okay, great stuff. By the way, definitely check out Pop AI, one of the most impressive sort of technology platforms I've seen in 2024. Still a very young business, and an organization that I think it's a platform. I think it's one of the genuine next gen platforms that is going to really change a recruiter's efficiency at multiple levels. I think of it as I think you call it a recruiting assistant, an assistant for recruiting, Sam. So it's basically someone who's going to take on all of the labor intensity, all of that work, whether it's screening CVs, creating interview notes, creating outreach messaging. All of that stuff is going to be part of the service that you get from Pop. And I do think it's going to be one of those that makes a huge difference going forward. It seems to me like one of those exemplar products that a lot of businesses, a lot of products will kind of end up looking like in terms of the experience that other people get. So do check it out. I think it's called Join Pop AI. I wonder if you can stick the link into the chat there, Sam, so people can take a look in a bit more detail. But okay, let's get some of our guests on show. Keisha, yes, this will be shared out after the session. So all you need to do is to kind of click on the same link and we should be able to bring you on, no problem. Unfortunately, Yasha is also ill today, so we're not able to bring her on, but we can bring Charles on. So let's bring Charles on now. And by the way, if we've got anybody in the healthcare sector that's kind of recruiting in the space or otherwise providing services in the recruiting side into healthcare, do let us know, because it might be one of these where it'll be interesting to bring you on, also to get your perspective. Charles, wonderful to see you again. Thanks for coming back onto the show. Charles Armitage, why don't you quickly introduce yourself? Who are you? What it is you do?
Hi, Han. Thanks for having me. Yeah, my name's Charles. I'm the co-founder and CEO of a company called Florence. And what we do is we build technology that helps healthcare organizations run their flexible workforce. We've been going since about 2017. Before that, I was a doctor, saw some of the challenges facing the healthcare workforce, and decided to build Florence to try and solve some of those challenges. And we're mainly based in the UK, but we've got a growing business across the world, teams in Canada and France at the moment.
Fantastic. I actually didn't know you were also a doctor, previously a practitioner, Charles. So we got two people here that have direct experience of working in the healthcare sector, that was so kind of that observed that situation upfront and personal, and realized actually we kind of need something to solve this. It's not going to be emergent within. I have to go and build something to sort it out. Let's talk about what the challenges are, and as kind of as honestly as we can. What are the staffing? What are the critical problems for staffing as far as you guys have seen it from the inside out? Or what do you think they are? Can you list them for us?
Yeah, sure. I mean, I'm happy to kick off. So I think it's important to consider some of the drivers, right? I mean, we just don't have enough people in this country, enough healthcare professionals to service the growing demands of our population. I think the first thing is obviously the population is aging. And so with an aging population comes greater prevalence of comorbidity, of chronic disease. People are living longer. And so this increased demand means that we require more people, and we just don't have that available workforce, right? So there's a growing discrepancy between demand and supply.
Quick interlude, Sam. What is the critical shortfall in labor? Do we have some numbers in our minds, like on average, like what are we missing in terms of nurses, doctors, and so on?
Yeah, I think in total, in terms of how now Charles will have a very probably a more granular view on this, but I think by 2036, 2037, we're expecting to see a shortfall of between 260 to 360,000 healthcare workers. So yeah, there's a long way to go, but maybe Charles has different figures to that.
No, roughly similar. I think today, if you think across both health and social care, so the NHS, and then also sort of adjacent private sector organisations, there are about 3 million roughly people or FTEs that work in across health and social care, and over the next 10 years, that number's got to go from 3 million to about 4.5 million. So we've got to add another 1.5 million net new people to the healthcare workforce to deal with some of this, what Sam mentioned, the demands of an aging population. Now, on the back of that kind of like extreme expansion in demand, that 1.5 million people, you've then got these supply constraints on the workforce as well. So if you look at like the demographics of, for example, the nursing workforce, more than a third of them are due to retire within the next 10 years, which is going to put a huge pressure on our ability to build that supply. You've got challenges around things like inward migration. You've got challenges around limited training places for medical schools and nursing schools. So you've got, at the same time, this demand is increasing massively by 1.5 billion people. You've got a real shortfall of both new people retiring, problems around immigration, all impacting on our ability to create a supply of the workforce.
Yeah, really interesting. I hadn't even thought about the demographics of the people currently in position. But if they're retiring out, so to say, and we haven't got a pipeline of people coming in, then that's kind of a hidden problem. You know, people can look at a spreadsheet and think, yeah, we've got these amount. Actually, those retirements can happen anytime. People can decide, you know what, I'm out. And then what are you going to do? So really, really interesting. And also, are we losing trained people to other countries as well? Like, are they going to other countries, to Australia, to Canada, whatever? I mean, what do you know anything about this?
Yeah, I mean, short answer is yes. It's hard to actually get exact numbers and statistics on that because there's not really a very rigorous data set. Like the GMC, the doctors regulator, like surveys its members about those kind of things, and I think the NMC does as well. But it's not a particularly reliable data source. I think if you look at we are losing quite a lot of UK trained graduates, especially in things like medicine, to places like Australia. You do see there was a big exodus of those sort of people in the last sort of 5 years. You do see them starting to come back a bit, though. It's not necessarily like people leave and stay away forever. But actually, whilst we've got like migration out of the UK of the healthcare workforce, the numbers actually coming in are much, much, much bigger. So like internationally trained graduates, both in medicine and nursing, are becoming an increasingly important part of the healthcare workforce.
Right. So basically, as a global talent competition, so to say, that's not the problem, in the sense that we're an attractive place. We're able to pull people in. We can afford to lose a few, but we can kind of more than make up for the shortfall there. The issue is currently that we don't have enough people as it is, and they're aging out. What are we doing with pipeline? What is happening on the pipeline? I mean, this is out of the control of all of us a little bit. I mean, are we doing anything to help more young people get trained in? And if that's not happening, well, what's the explanation as to why people aren't coming into the healthcare sector?
Yeah, sure. I mean, from my point of view, I think on the ground, when I was a doctor, maybe 6 years ago now, what we were beginning to see was the training of people for new roles that would try to kind of bolster what you'd expect doctors to be doing. So physicians associates, for example, a lot cheaper to train. The training time is much less, 2 or 3 years, whereas training a doctor takes 6 years and is very expensive. And they would essentially be able to do the role of a very junior doctor. So I think that has become more and more prevalent. We are seeing that role has actually expanded across both secondary and primary care. And so, I think that's one of the mitigation strategies that I've seen actually actively deployed on the ground.
Yeah, so basically just getting the adjacent sort of skills in, and making sure we kind of open the aperture somewhat, to make it easier for people to transition into the sector. Okay, cool. What are the other sort of constraints that are causing us to have this staffing problem? We know sort of about the demographics. We know a little bit about the overall sort of discrepancy between the supply and demand. What are the other factors, do you think, that are causing us to not have the labor we need?
Yeah, I mean, there are other kind of, there are macro factors, more macro factors than beyond just demographics, I guess. You know, with Brexit, it's led to you know, a loss of staff, reduced influx of healthcare workers from EU countries specifically, but we are getting, as Charles was saying, healthcare workers from elsewhere. But then also kind of more micro factors like, you know, the day-to-day working environment. So, you know, there is, you know, training, the capacity to actually train healthcare workers is not there. You know, the numbers that we need to train in-house, just, you know, it's very difficult to hit them. And partly due to the high costs that I was talking about when it comes to training healthcare professionals, particularly doctors. There are pay issues, and it's partly the reason why doctors nowadays are kind of looking at Australia and New Zealand, particularly those who have been trained here in the UK. The pay is pretty, you know, it's pretty low when you're a junior doctor. I think, you know, to be completely transparent, when I first started as a foundation year one doctor, my base salary was £26,000, and that was in 2016. So, you know, it's pretty dire, and, you know, you spend all of these years training, and you look at your friends who are kind of working in the city, and they're, you know, they're starting on you know, 2, 3, 4 times as much, and, you know, it is difficult. It is a vocation, but it is difficult when you're a young person just trying to kind of live in London, particularly. And so there's that, and then of course, like, just the high turnover and burnout, very high attrition rates. Job pressure is very high. There's very high workloads. It's unsustainable in a public sector setting. You know, it's difficult to provide your workers with you know, a great working environment, and therefore the attrition rates can be pretty high.
Yeah. So the basic idea, I mean, the poor pay, I think, is really tough to hear. But obviously, you can compare that salary to what a person with a similar education would get in another field, and it's very, very difficult to see that as competitive. And of course, the job is not easy. It's particularly challenging work, mentally and physically. So lots of things there. All of these things seem fairly unsurmountable, guys. We're building up sort of an image of, oh my goodness, this doesn't seem like a soluble problem. But you both have made efforts to try and solve it. So Sam, sticking with you for a second, before the Pop AI sort of adventure you're on now, you mentioned you built something to try and accelerate sort of, or make the recruitment more efficient. Can you give us some context as to what that situation was? Like, what was the inefficiency that you were dealing with, and sort of what was the thing that you put together to help make that more efficient?
Yeah, absolutely. And it's funny because I think actually Florence are doing an amazing job of doing this at scale properly, at, you know, at a kind of national and international level now. But, you know, we tried to do something fairly similar at a kind of trust level. And so essentially what the problem I noticed as a first year junior doctor was that often I'd turn up to a shift, and several of my colleagues just wouldn't be there. You know, somebody might be sick, others might just be off. They might not be on the rota at all, so they were actually known to be off. Others might be kind of redeployed elsewhere, and so there will be an unsafe number of clinicians on the ward at that time. And so there was always this bare kind of minimum of staffing that would be required to make the ward safe, or make the area of the hospital safe. And very often we kind of dip below that. And it's because of just poor kind of forecasting and planning and organization. It's very difficult when the organization is so kind of complex. And so we decided that actually, wouldn't it be great if there was a way of notifying, of firstly detecting when that gap would exist, notifying those who might be available to fill that gap when that gap exists, understanding if they're available, if they're interested, if they meet the skills required, and then actually providing them the infrastructure to enable them to fill that gap and get paid for that shift. So we went about actually building a product that did that. I remember being a first year doctor and emailing the chief executive of the trust and seeing if they'd be interested in supporting us. And to my surprise, they actually responded. And so a week later, I was kind of I was invited to a board meeting to present the ideas that I had. And they decided that they at a board level at least, it was approved that I would be allowed to build this product and actually try it out at the trust itself. This is Queen Elizabeth Hospital in Birmingham. So yeah, that's how it went. So for the next 6 months, I was building this product alongside all my colleagues, and it was an amazing adventure. And it did actually work pretty well for a short period of time until other startup teething issues started getting in the way.
Yeah, really interesting. You've just painted a picture here, which a lot of people might not be aware of, but obviously healthcare, especially in hospitals, is a very complicated situation. The resource forecasting has got to be very difficult to be accurate on, simply because people need to be treated. You have no idea how much effort is required for that person. It's a biological entity. You have no clue whether it's going to take you 2 minutes to resolve a problem, or maybe it's a 2-hour commitment. And obviously human beings are doing this, so they're in and out and they've got issues. If they're ill, for instance, Yasha today couldn't turn up to this event. That happens. And if it's a paper-based system, or it's a system where the data is fragmented in some way, people don't know, and that causes all kinds of cascade effects within the system. Charles, let's go to you on this. Yeah, Florence, I mean, I guess did you encounter a similar situation? Was that the inspiration for you to build something like this?
Yeah, very similar actually. I was in a different hospital, I guess, dealing with slightly different challenges, but like definitely identified the same issue, which was that ultimately, you have frequently understaffed parts of the healthcare system, and really the only lever at that time that healthcare providers had, or healthcare organizations had, to try and fill that staffing shortfall was through like locum agencies or staffing agencies. And so I would sometimes do locum shifts myself at sort of like weekends or holidays for a bit of extra pocket money, and just thought the analog nature of the way that was set up was really inefficient. So, you'd be having to phone or email your recruitment consultant, get sent to places you didn't necessarily want to go, always have to chase up earnings, never getting paid the right amount, paper timesheets, all these different things, turning up to hospitals, not necessarily going to the right place, shifts getting cancelled. It was a real mess. And so there was clearly a real opportunity to, in a very similar way to Sam, to use technology to try and like match some of that supply and demand, right? So finding where the staffing shortfall is, and then in the most efficient way possible, getting the right human capital into that gap as you can. And so I also started to build a product, try and get it to try and solve that problem. Went a slightly different route to Sam, rather than going immediately to market in the NHS and via the place I was working at. We just phoned out around a load of like local nursing homes who had similar challenges with their nursing and care workforce, and found someone who'd be willing to give it a shot, and the rest is history.
Yeah, very interesting. So at another level, there's an ICT problem. So we talked about overall as a staffing issue, but there's also a sort of on-demand issue, so to say, if we can use that language. So basically, there may well be people available to supply healthcare services, but they are not connected to the demand when we need it. A lot of that's down to the fact that the information is probably highly fragmented. A lot of it may not even be sort of digital. It may well just be written down somewhere. I think you mentioned there was a rota, Sam. So that tells me it might even be a chalkboard, right? It might even be a physical rota back in the old way. So we obviously need to digitize a lot of this. What are the things that get in the way of the NHS becoming more digital? I remember in the sort of noughties or so, my interaction with the NHS was trying to recruit individuals into the National Programme for IT back in the day. That was 20 or so years ago, in an attempt to try and, we're going to get like one patient, one record. We're going to get a unified system across the entire country. I don't believe that worked at all in terms of how that program worked. I think it was a bit of a white elephant in the end. Where is the state of play? Why can we not do this in the UK and create this system that actually seemingly would resolve a lot of these issues? What have you found, both as practitioners and now as kind of entrepreneurs, that have been the blockages to this?
Yeah, I mean, I can have a shot at that. So I think from my experience trying to support innovation with the NHS and try and get products embedded within that organization, it's extremely difficult. probably three big buckets of what the problems are. Like, one is funding, two is a sort of cultural risk aversion, and three is just like the organizational design and the setup of the system. So, the first one, funding, is everyone knows that there's not enough money, and any money that does come tends to get allocated on really like short-term solves to problems. So even if it's labeled as like, the tech innovation funding or some big capital expenditure to go and upgrade everyone's IT system, it can often get funneled in like really creative ways into basically like spinning up a new ward for winter flu season. So it's very hard for leaders within the healthcare system to like plan long term around how they like innovate forwards. And I think like even running my company, if I didn't have line of sight over our budget process for the next 2 or 3 years, it'd be very hard for us to make decisions. If you're running a multi-million, sometimes even billion-pound organization, that's even more challenging. So like funding is number one. Number two, there's a real cultural issue within, well, healthcare in general, but especially within the NHS. So, one of the core sort of like cultural tenets of healthcare is first do no harm. It's a very risk averse culture. So, you arrive on your shift as a doctor or a nurse, and like job number one is get to the end of your shift without anyone dying. And if you manage to do that, then you can broadly like pat yourself on the back and like you've had a good day. The problem with that is it breeds a real culture of like people being unwilling to like stray from the protocol. And that like permeates at every level of the organization, that like it's very hard for people to take a risk or a bet on something new. And actually you see often, maybe due to quite a lot of burnout or like inertia at like the ground level, people can be very resistant to change and hugely grumpy about doing something new. And that's like a really, really challenging and damaging place to try and innovate in. And then the third thing is, I think, around the organizational design and how the NHS is structured, is that, the NHS in theory is one of the biggest organizations in the world, which you'd think would be great for scaling a product. But the problem is that it operates in a really federated way with very, very convoluted decision-making processes between hospitals and trusts and ICSs and ICBs, and also the Department of Health and Social Care. And so whilst you have this big organization, decision-making is hugely federated and owned by a load of people. It's very unusual in that you can go to the CFO or the CEO of a trust and expect them to be able to make a decision about something, but they often have to get signed off by different boards in different places and central government and all this kind of stuff. So it tends to move extremely slowly, and you have to get huge amounts of buy-in in order to get anything adopted. Mm-hmm. So it's very hard.
Yeah,
that's brilliantly kind of explained, Charles. Thank you so much. It really does paint the picture of sort of a huge system, a huge bureaucracy that's difficult to navigate, also underfunded, which means that there's a lot of crisis management seems to be the default mode, so that it's hard to put in sort of resources that you do have for something more strategic, because there's 10 fires that need to be put out now. I got to put 3 of them out, deal with that, deal with the rest tomorrow. Really, really interesting. Sam, you got anything to sort of observe there before we move on to what potential solutions we might create?
Yeah, I mean, the question gives me a bit of PTSD from when I was trying to sell into the NHS trust that I mentioned before. So when we were developing that very first product, it was called Swift Locum. And for the first 6 months or so, we agreed with the trust that it would be a free product for them, because they were kind of our design partners. But we had to, in that time, we had to get on a framework so that we could actually sell to them. So we had to get on this kind of NHS software framework called G-Cloud. Very difficult for an early stage startup to do. We had to talk. We had many conversations with all kinds of stakeholders to get approval. Obviously, staffing is a critical part of for everything, essentially, when it comes to actually running the NHS trust. So it had to actually work. We had to spend pretty much hours every day with the HR team to make sure things were working correctly. So and they were very risk averse, as Charles was saying. So, it's all of the things that create like a very hostile environment for innovation. And eventually, what happened was they ended up so the board ended up liking us as people, and they liked the idea that these junior doctors were going to develop something homegrown for the trust, and I think it would make quite a good story. And there was a lot of emphasis put on how the trust looks on the outside world, and how they position themselves as a center of innovation. And very candidly, the CFO gave us a figure, right, for an annual agreement that could kind of fly under the radar when it came to budgeting. It's very low, and well, it was candidly, it was £30,000. And essentially, what happened was we, as very naive founders, Googled what is a typical enterprise level agreement ACV for in the NHS. And every source we looked at was 6 figures. So we went back to the CFO and we said, "This is ridiculous. We're being fleeced here." And then suddenly it had to be escalated to other people, and then the deal was completely it was shattered. So that's kind of the story of how that worked out. We should have taken the 30K, because actually that would have been not a bad deal for your first contract trying to sell to the NHS. But essentially that's how it worked. Never told that story before.
No, and thanks for sort of risking your sort of post-traumatic stress disorder there, Sam, to share it with us. By the way, I'm respectful of both of your experiences on this, because I totally understand that it may well be had a very sort of difficult emotional journey, sort of going through this process to where you guys are now. I think we get the picture of where we're at, but let's talk about what we can do about it. You both wouldn't be doing what you're doing unless you thought you could do something about it. So what are the actions that can be taken? Just seen Matt there with his comment to say, yeah, you know what, there's 200 plus entities that may all operate under the rubric of NHS, so to say, may take money from the NHS, but there's local decision making. You've got to treat them maybe as different entities there. And yet on the supply side, I think the G Cloud thing you were talking about, Sam, that sounds like almost like a preferred supplier type of arrangement. So young innovator, new company, you're not getting in. It's like you don't have the track record. So you might have the best idea, but you know what? Not happening. They're going to go with, whoever, Capgemini or whatever it is, whoever that they have sort of a long relationship with, or has previously already sold into this Palantir or somebody like this, somebody horrendous like that. Anyway, what do we do about it? What are your, if we could bullet point a similar list of, okay, if we want to solve these problems, this is what we've got to do. What would you suggest that can be done, and who should be doing that?
Charles, do you want to kick off?
Yeah, go on. Look, I think the workforce challenges facing the NHS are not unique to the NHS. They're prevalent in basically every single healthcare system in the developed world, and there are only a very few countries in the world that are kind of like net exporters of healthcare talent. So we're not alone in this, and there are some people that have solved it, are solving it relatively well. Number one, I'm actually pretty bullish on the future of the healthcare workforce, because if you think, especially, the advent of AI and the disruption that's happening across the labor marketplace generally, not just within healthcare, is massive. And so, you fast forward 5 or 10 years, a lot of the jobs that, we see today as jobs within society won't exist, right? Taxi drivers probably won't exist. Software engineers probably would exist, but in a very different way. The list goes on. But healthcare as a career path and a place where labor is required is going to continue in perpetuity. I think it will look very different. Doctors, I think, are going to be replaced relatively quickly, because I think doctors are a relatively you're just an LLM, really, because you're just taking data inputs from history and examination and investigations and imaging and biochemistry, and coming out with a diagnosis and treatment plan. Now that's a really automatable replaceable by artificial intelligence thing. But I think if you look at like what we consider like slightly down the rung in terms of like specialization or skill, which I think is a bit of a misnomer, but things like nursing or care, like these are jobs that are really, really hard to automate, really, really hard to replace with artificial intelligence. And I think as like these wholesale changes to the labor market, we'll realize as a society that actually healthcare represents both for like fulfilling and also like safe long-term career for a load of people. So I am very, very bullish on the future. How do you solve it?
Hold that thought for a sec, Charles. I just want to come into that point of sort of almost a society-wide rebrand of the career, because I think at one point, I mean, again, I'm now speculating, but I at one point being a healthcare worker probably was like quite a credible and attractive thing to do. I don't know. It was like, but somehow it kind of became something that, you wouldn't do as first option. It became, reputed to be very difficult, and it became less and less attractive. And obviously we know that public sector pay has really suffered over the last decade or two, I believe. It hasn't kept pace with inflation. So in reality, it became a less attractive career. But if we can reset what we pay people to do the job, and really make a push to describe the requirement and kind of rebrand it as a career path, then potentially it attracts more talent coming in at that bottom of the funnel. So that is an important task of work for all of us to think about. And very interesting, as you mentioned, there may be a reversal of status, shall we say? Because right now there's a hierarchy: doctor first, nurse second, so to say. But what if a doctor is just an LLM? Maybe the nurse is the person that has the LLM and deploys the LLM rather than the other way around. We do need the empathy, because even if a robot could technically do the service better, I suspect the human being would want the human to do it. So it's one of those more defensible positions where you just need someone to hold your hand. I remember, again, this is not a sob story, but I have been in A&E before. I have been on the slab, and there was a moment where I wanted the nurse to hold my hand. I was terrified. I needed someone to hold my hand, and she did. And I was just thinking, wow, yeah, I can't imagine R2-D2 doing that, or me being particularly keen for that sort of experience, right? So yes, human only. Love it. Charles, sorry, continue the second point you were about to say.
So I was going to say how you solve it. So, you talk about pay, and yes, that's really, really important. And I think that one of the problems we're going to have to kind of tackle as a society, as taxpayers and recipients of healthcare, is understanding and appreciating like the innate inflationary like drive that healthcare brings. So Sam mentioned it earlier, right? Like, people are living longer and longer with increasingly complex complex conditions, and you're almost a victim of your success with healthcare. The better you get, the more you have to spend on it. And so I do think healthcare workers need to be paid a lot more across the spectrum. Absolutely. Otherwise, and it's not just about the, ye old nurse doing the job today, oh, don't they deserve more pay? I'm actually kind of framing it in the terms of like, we as taxpayers expect and demand a certain level of healthcare, and will continue to do so over the coming decades. Like, if we want to get that extra 1.5 million people into the sector, we are going to need to pay more for it. So I'm coming at it much more from like a recipient of healthcare rather than a deliverer of healthcare. So yeah, that's number one for me, pay. And then number two, and we mentioned it a bit earlier as well, is like, I think we need to have a whole load more flexibility across the workforce about skills and training. And there's a real kind of like protectionism that exists within healthcare careers where, there's this debate about like physician associates who do 2 or 3 years training and then can like take on some of the roles of doctors. And doctors feel in some ways quite threatened by this because their position is necessarily being eroded. And they've done so much more training to get there. And like, I empathize with that. That's really an important point to recognize. But like, we've seen historically, when different job roles expand, it's been really successful. So, nurse practitioners, nurse prescribers, people being able to train on the job from going from a care assistant or a healthcare assistant to being a nurse. These are really, really important things. And actually, if we want to be able to deliver healthcare at that kind of level, we need everyone operating at the top of their license. So like, kind of who cares about like what your training has been to get to a certain role? If you can competently and safely perform the job that you're being tasked to do, I think you should be able to do it. And I think we have to break down some of these barriers between like traditional descriptions of like healthcare assistant, nurse, doctor, and allow much more transferability of skills and jobs across those different jobs.
Yeah, really, really good, Charles. 2 points. I want to address them real quick before going to you, Sam. Firstly, on the pay, you ask man on the street, everyone would probably say, hey, yeah, I'll pay a little bit more tax to have a better NHS. But the problem I think we have is that like we don't have any transparency as to where our tax goes. Like there's a break on there. So we pay more tax, but does it actually go to healthcare? Like where does it actually go? Or does it go to, I don't know, building an aircraft carrier or something? Now maybe you do need the aircraft carrier, but maybe some transparency as to where the money goes would make it easier for the population to basically accept higher tax burden. Because right now there's no transparency on that at all. We just see the number go up and like we don't see an improved service, or we don't actually see any outcomes that make a difference. So I think one thing that I don't know any government that does it. I think
that's one of the arguments behind potentially changing the funding system, right? Because if you fund it via general taxation, then basically it's impossible to get that transparency. If you have like a more hypothecated tax or like a insurance-based system or whatever, you as a consumer will be much more able to like choose and see where your money's going. So yeah, I agree. Like the transparency piece is because there's a huge amount of waste in the system as well. There's no doubt about that at all.
Right, and I think a lot of people that creates a reluctance for people to support it. Very similar to charitable donations. Is like I think loads of people in the UK, I think, are particularly charitable culture, but I think we've now become to know that actually we don't know where the donation goes. Is it funding some sort of organization? Is it doing stuff we can't see the transparency of it, and that suppresses the desire to or the impulse to donate. So transparency in some way in pay is super important, and attacking the cartelization of the profession, I think, is definitely true as well. Like whenever you give people a title or you give people some sort of a status, of course they'll defend it, and that is to their interest, but it is not in the interest of the wider group, which is what we have to do. Sam, what are your solutions to this problem? How do we create a sustainable healthcare sort of approach?
Yeah, of course. I think so. One of the things that's very apparent as a clinician, and then also somebody who's kind of working outside the system, is that the friction just to turn up to work is extremely high. Right, the friction to actually get onboarded as a worker. So let's say, like, even if you are kind of years into your career, but you start at a new organization, a new NHS trust or a new general practice, the friction to actually get to day one of the first day of your job is extremely high. There are lots of kind of onboarding processes. There's lots of documentation. There are various kind of questionnaires that you have filled out many, many times previously. So like fire safety, safe lifting, all these types of like mundane, repetitive questionnaires. There's, all of the skills that you've developed over your career that you have to then kind of validate, provide evidence for, but you've provided that evidence previously elsewhere in the NHS. So it's extremely annoying. And then not only that, but like, let's say you pick up an extra shift at some other point, then, the communication between you and the HR department and other doctors and the coordination is just unnecessarily complicated and relies on people, right? It relies on people actually, like some person in HR taking kind of ownership of trying to coordinate the whole thing, but obviously you yourself have ownership over it too. So there are so many friction points in the system, and I think like systematically we are beginning to address a lot of these. I think Florence is doing an amazing job addressing, many of these friction points. Our focus at POP really is on the communication aspect between a candidate and their place of work, or the entity that kind of sits between the candidate and their place of work. Communication is, one of the it's something that is that there's a very high volume of during the hiring process in healthcare, that is extremely fragmented, takes place across lots of different systems, has already happened before. There's no system of record for it. So bringing it all together into an intelligent kind of platform that allows you to automate communication with the clinicians that you're recruiting, automate the processes of the documents that you need, the validation of those documents, reach them where they are. So using mobile channels like WhatsApp, where people's friends and family are, actually cutting through the noise of email or other channels, and having some way of, automatically updating the system of record or the CRM so that a human doesn't need to do that manually. These are, I think, table stakes of what, where we really need to go in terms of the technology here. And that's kind of what we're building. But, obviously I'm biased when it comes to answering this question.
No, really, really good. And I read sort of an article maybe a year or so ago. It was the US guy dealing with the US healthcare system. And it was a really interesting post. And he mentioned something that was really quite profound for me. He said, look, he realized after a certain period that there was no system, so to say. It was just simply a collection of like mini systems, micro systems that he had to go and negotiate and ferry the information from one system to the next system, even though it was all labeled under the same thing. It was like, actually, no, that's not how it works. Like, you have got to manually move this around because those mini systems are not connected. And it sounds like the NHS here in the UK has a broadly similar type of situation where there's lots of different subroutines, sort of say, going on, local sort of stuff, not centralized. It takes a human being or several human beings to kind of massage it all through. That's where the frustration is. A couple of comments in the chat there that says, hey, listen, we need to centralize it. And then someone's saying, actually, we are centralizing it. What is happening with the centralization? Are they making sense? Is this do people know that perhaps this is a destination we need to get to and there's work being put towards it? Or is this them referring to something that's alien to us? What do we know about the centralization?
Yeah, I mean, so I actually, for some reason, I can't see the comments. Yeah, I'm not sure why. But I mean, centralization, big term. I mean, it could, depends on kind of what we're referring to here. There is obviously a level of centralization that is happening across the NHS. There is a big thorny issue, right? Because obviously some centralization is good when you want to standardize processes, but actually we have tried centralizing, let's say, for example, the way that secondary care is funded. And in many ways that hasn't worked very well. And what we've seen is then the decentralization, because actually trying to make decisions at the very kind of at this new kind of layer on top of, let's say, multiple NHS entities. Well, there tend to be quite a few steps away from actually what's happening on the ground. And so it's very difficult to make decisions, funding decisions. And so actually what we've seen is some NHS trusts in recent years have come together and then suddenly split apart again because it just wasn't working. So yeah, it's a bit of a thorny issue. It doesn't work in all cases. And of course, I'm talking from the financing perspective here.
Yeah. And your thoughts on that, Charles? Centralization or not? Is it just too big a thing to swallow?
Pass. I don't know. I think that like the idea of having like in theory the way it works at the moment, I think is probably actually not a bad setup, in that you've got like a central command and control structure with a centralized strategy, with like centralized funding. I think that's primarily good, with then like local federated teams that can make decisions for their own like areas or places. So I think that's like conceptually good. But I think, breaks down a bit when rubber meets the road, because ultimately, and why is that? Well, because this centralized structure is like, by its definition, like very political, which means that, decisions are made politically, and because they sometimes generate headlines if you're being very cynical, rather than actually making decisions or what's in like the long-term best interests of the of the NHS.
Yeah. Okay, two quick questions before we kind of bring this to an end. Firstly, we need to talk about the kind of new change of government. It's hard to say new government, but it is a change of government, and we might see a different philosophy, a different kind of perspective. And there's even been some changes already, particularly in terms of this working status and stuff like this. So how do we think that that's going to affect recruitment within the NHS? Any thoughts on that? Charles, maybe you've got immediately some ideas in this.
Well, I mean, if you maybe not so much in the NHS, more in social care, which is as big as the NHS and looks after a lot more people. The big thing coming down the road is to do with changes to employers' national insurance contributions. So that's going to have like a real knockout effect on care providers across the country. And obviously, the NHS is exempt from that for some reason, and so that's going to have a dramatic impact, I think, on people's ability to hire. And I think if I speak to providers across social care at the moment, they're all that, and also the impact of like increasing the sort of like national living wage for social care is going to have a massive impact on their financial health and ability to function. So big changes coming down in April.
Yeah, so quick context on that. Basically, national insurance contributions, essentially, I think whatever size business, you're going to have to start sort of contributing to NI. And that obviously is going to add operational costs to any organization, which will suppress hiring. So, and we've just had sort of some updates, I think, earlier this week about sort of the job growth, obviously not, so it's kind of reflecting that. So it's actually job decline. So yeah, more issues to come. Second thing, let's talk about technology. I mean, I'm thinking we need a moonshot. We probably need to have like something like, technology. We don't want to say it's going to be the thing that solves all problems. So I wonder whether we can be wrestling away with all of these processes and still not get there. Perhaps it is requiring something that changes the game. Can AI solve any of this? Does it move us forward? If so, how do you anticipate it helping this situation we have?
Yeah, I mean, I'm happy to kick off on this one. So I think the kind of situation that we've described, the complex process or processes of hiring that require multiple different stakeholders, that require lots of different kind of communication between different people, but then also an interaction with various kind of databases. This is kind of ripe for an ecosystem of agentic workflows, I would say. So I'm sure this is a term that many have kind of come across recently or perhaps on social media, perhaps elsewhere. But this notion of taking these kind of micro processes, as Hung was describing, and actually building a dedicated agent that is able to orchestrate those processes, and then having an agent that is a specialized agent that is able to do all of those processes when it is triggered to do so. So there's actually a lot that actually can be done here. So for example, let's say that a gap is identified in the rota. So having an agent then reach out to doctors who are, let's say it's a medical shift, it's a doctor shift. Having an agent reach out to doctors who might be available to work work that shift at that time, understanding whether they're available, whether they have the right skills. That information should be on file. And then once you have somebody who is actually available and the rota lines up and they've agreed, then actually triggering in the system of record that they are going to be the ones fulfilling the shift, and then having another agent actually orchestrate the ability to pay that doctor for that shift. All of these situations, all of these processes are done manually right now, but actually there is absolutely no reason why these algorithmic processes couldn't be handled by a machine. We just need to bring that ecosystem together.
Yeah, really good. So there's loads of these micro processes where there isn't really a decision making, like there's not a human decision required really, because certain things will determine whether this is a go or no. That could be serviced by agentic AI. Otherwise, you would need probably the subject to do it. or you'd need to hire a coordinator or an administrator to do it. And that's, that's not going to help the problem by throwing more humans into it. It's actually not going to be the solution. You need to take the humans away and have the bot essentially harvest the information, ingest it, and then move it to the next place. I think we can see a future there. I think just about we can glimpse what that looks like. So very promising. What about your thoughts, Charles? How much confidence do you have that tech might sort of Gordian knot some of these issues? What are your thoughts?
Well, I think it has to. I think when you look at product. So, okay, two issues in NHS or healthcare poor performance. Like, one is there's not enough people and not enough money, but two is just that it's been really lackluster productivity growth. And so, if you look at how many more people work in healthcare in the UK now than they did in 2019, it's like massive. I don't know the number off the top of my head, but it's very, very big. But productivity has been the same, if not, well, productivity is lower, output has been the same. So, and like, what are the hallmarks? What are the determinants of productivity? Well, one of them is sort of technology and efficiency. So we have to be better at using technology to solve some of these problems. And actually, one of my core realizations of moving from being a doctor to working in the company I work at now, where actually productivity and performance are the pinnacle of what you're trying to do in my job at the moment, is really all about productivity and performance. That really just doesn't come across in healthcare at all. And there's a real sort of, anti-productivity or anti-being thought of as productive beings. And I think a lot of that has to be solved by technology. So I'm sure we'll do it. We have to do it. Otherwise, we'll be in a lot of trouble.
Yeah, really, really interesting. And who knows? Maybe takes us back to recruitment in a way. Perhaps one of the things we need to be doing when we're bringing people into the healthcare sector is to hire people that are, let's say, a little bit more technology aligned, let's say, digitally aligned. Hopefully we can see that. Hopefully that may be an organic thing if we're starting to recruit younger people into the organization. But perhaps that needs to be one of the bullet points that we have when we're looking to recruit people. Like, how fluent are they with technology, and do they see sort of the technology advances? And if we get enough kind of density of people that are of that type, then you can imagine some of these issues might move away a little bit. So very interesting indeed. Let's leave it with a positive note, folks. What are your what's your best case for how you see the healthcare sector in terms of recruitment in the next 5-10 years or so? Let's say a couple of things go our way, with you a bit of luck. What does the best case look like for you guys? Sam, let's go with you first, and then we'll go to Charles.
Cool. So I would say better conditions for healthcare workers, firstly. So it's not just about pay, of course. Pay is a factor, but it's also about culture. I think there's a real cutthroat culture within, particularly amongst doctors, when they're training to almost kind of, compete really hard against each other in order to get the best opportunities. And, often that can result in pretty toxic situations. And, I've definitely been there in the past. And so we need to move from that kind of culture to one of collaboration, and where good patient care is incentivized rather than, kind of getting certain experiences in a hospital. And then, of course, I think a far more efficient way of ensuring that we are adequately staffed. I think we actually have a long way to go before we even think about the supply of staff. There's also a lot of work to be done simply in the reorganization and the increased efficiency of the existing workforce itself. I think it's highly inefficient the way that we staff our healthcare system. And I think there's a lot of work to do there. And then, of course, once, I think that needs to be addressed in parallel with the supply issue. So, yeah, I think those are probably the top three for me.
Excellent. And by the way, the deployment of staff that can obviously be supported by AI as well. One of the things that we're seeing in the corporate sector is exactly that. How do you redeploy, redistribute sort of labor to where needs are most? Charles, your thoughts, best case, what does it look like?
I think best case is we solve some of the underlying productivity issues, have better technology, more investment in technology and infrastructure in the system, solve some productivity, probably much better management structures and talent. I think that's always we haven't really talked about it now, but everyone loves like mugging off the managers in healthcare, but actually you need really strong management structures in order to generate that productivity and efficiency. So more investment in technology infrastructure, improvements in managers and talent within managerial class, and then increase the headcount, more funding, get more people into the sector.
Yeah, fantastic stuff. Guys, thank you so much for your conversations here. I'm sure we could continue this conversation, and we should continue this conversation because it's stuff like this that's going to help elevate the issue. Hopefully, we've managed to, it's certainly educated me listening to both of you in terms of what the challenges are and what the potential solutions are. So thank you very much, Charles Armitage. Thank you, Sam Desi. It's been great having this conversation. We're going to have to leave it there, folks. Thank you so much for joining us with this redux of the conversation. We are going to rebroadcast this, obviously, for the folks who weren't able to watch. It is now replayable as soon as we come off air. And it is a topic that, of course, we all need to care about. We are all in touch with the NHS, or we're all in touch with the healthcare system, regardless of which country you're into. And hopefully you won't have the need for it, but we just never know. And we need to understand, no matter where your ideology might be, that our commitments to making sure we have adequate and superior healthcare is in everyone's interest. Okay, folks, that's it. Thanks for watching, everybody. It's been great having you. We'll be back later this week. I think we've got the final show for 2024 on Friday. It's going to be an open mic Christmas special. Basically, all comers. If you want to come on screen and say hello, please do that. It's going to be just a look back and a celebration of the industry. I'm going to bring on all of our guests that are still around in front of a computer that want to come and say hello. If anybody has anything to share about what's happening in 2024 in the world of recruiting and HR, you're more than welcome to come on stage and on screen to share your thoughts. Okay, that's about it, everybody. Thanks for watching.